Assalamu alaikum and welcome everyone to our first webinar. Today we're going to talk about or present or discuss the new era of remote heart failure management. We are delighted to have you join us today as we explore how remote monitoring and digital health technologies are transforming the care of patients with heart failure. This webinar will highlight the latest advanced practical application and future opportunities in remote heart failure management with the goal of improving patients' outcome and quality of care. Tonight we'll have two speakers from Saudi Arabia, Dr. Fahmi and Shamsa Al-Anazi, and we're going to discuss two important topics and advanced heart failure and remote monitoring in the heart failure patient. The first talk will be given by Dr. Fahmi and talk about transforming heart failure care throughout remote hemodynamic monitoring. And the second talk will be given by Shamsa and talk about or discuss about the evolving role of the heart failure nurse and the remote monitoring. So I will start to introduce our first speaker, Dr. Fahmi Abdullah is the head of department and consultant of advanced heart failure and transplant and at King Fahad Medical City in Saudi Arabia. He completed advanced training in heart failure and transplantation and mechanical circulatory support and has extensive experience in the management of heart failure patient. Dr. Fahmi is actively involved in the clinical research, education, and regional initiative focused on the heart failure, transplant, and innovative remote monitoring technology. Dr. Fahmi, welcome, and the floor is yours.
Thank you, Dr. Anada, for this introduction, and thank you for all the committee for inviting us to share our knowledge and experience from King Fahd Medical City in this new era of telehealth and monitoring the patient. If you allow me, I will share my slides. So today we'll talk about a new era in managing the patient of heart failure, which beyond the symptoms. My presentation will start with the introduction. In general in heart failure, then we'll pass to discuss what's the traditional telehealth in heart failure and what's the new or what's the more advanced in telehealth. Then we can discuss some of our experience in case scenario of two case scenario in management of heart failure, and we'll pass that to reach what's the prognosis and what's the management and what's our protocol at KFMC area. So starting from in general heart failure, as we know, heart failure is one of the really highly endemic disease. We are talking about more than 64 or 65 million patients in the world. And we are in the Middle East and especially one of the highly prevalent area. And this one of the data showed here that showed 1 to 3%, almost 2.5% of our population, they have heart failure disease. And actually, the prevalence is not only the burden of the heart failure. Heart failure disease, this is disease usually in most of the patient, we talk about more than 90% of the patient, it's not curable disease. This is progressive disease. When it starts, it's continue and depend on the stage from C, D to more advanced and palliative care. And this is give it also more highest risk of mortality, starting from the 10% to 20% in the stage C heart failure to more in advanced heart failure, reach more than that one to reach 40 to 60% of mortality. And not only that, this is the burden in heart failure. It's also making high burden on systemic care in general, starting by highly costly disease. And many trials estimating the cost in heart failure in general, and one of the trials that including 179 countries that published in 2021 estimated that exceeding 280 billion US dollar. And estimation by the patient, and I'm not talking here an advanced heart failure patient, I'm talking mainly about the patient who is more stable to early advanced, that estimated per patient exceeding more than 85,000 US dollar. And if you think the cost coming from what we give medication, clinic visit, what we are doing, the imaging like echo and more, sometimes cath, actually is not true. Most of the cost in heart failure, and I'm talking about the trial coming from US, from Europe, and even from our region, is mentioning that most of the cost, 70 to 80% coming from hospitalization. So is hospitalization heart failure is really making more burden and more challenge in the management. For that long time, we think how we can decrease this hospitalization, how we can prevent it, and improve the patient's symptom and quality of life. And initial thought, usually, that we can monitor patient at home from his symptom, from his signs, from his early signs of heart failure, and depending on early signs, if we can detect it, whatever the way, we can early intervention, so we can prevent the hospitalization. So monitor at home, early detection of the symptom. This can lead to the early intervention, usually by the oral medication, and this can prevent hospitalization. And the traditional telehealth starting by the usually or long time when we are calling the patient from the clinic, follow them after a few weeks, every month to check their symptom and maybe adjust their diuresis, to more advanced when we have the application and the mobile WhatsApp and sending for them reminding message and questionnaire, to more advanced now what we have wearable monitoring device as a watch, or the traditional monitor the patient at home like blood pressure and scale for their weight. And actually the main issue in the traditional telehealth, that usually we are waiting for the patient to be mildly symptomatic, so he's already start to be decompensated, lower lymphedema, increasing his weight, mild shortness of breath, this is starting to be decompensated. And usually the management or intervention is early, which can benefit many number of patients, but many patients still they will not respond as they are starting in the decompensation, and this usually lead to the hospitalization. So we are moving forward in the telehealth, not only to detect the patient when he starts to be symptomatic, we are going to discuss now how we can early detect before the symptoms. So in the area of preventing the symptoms and preventing the decompensation. And this coming from pulmonary artery sensor, which very small sensor implanting through the simple procedure, day case usually, and the procedure is mostly like in the right heart cath. What we are going to implant the patient within almost 30 minutes to maximum 45 minutes, and the patient, he can go home in the same day. And this small device, actually, it's very small to be implanted in the pulmonary artery, and its size very small, less than 1.5 centimeter. No need to charge this device, and actually it will send for us daily data from the patient BA pressure. And you can see the data was sent from this device, like exactly in the right heart cath. You can see the pulmonary artery, systole, diastole, and mean, and also the heart rate. And you can see in this box. And not only this one, this daily data also can monitor the patient trend. So we can trending this patient to see how's the change in his BA pressure. And the main idea of this sensor or this device, that we can record the patient when he's euvolemic to know his baseline BA pressure. When the patient start to be congested and LV pressure start to be increased, initially the BA pressure will go up before the patient he will be symptomatic. And at that point, we can interfere with the patient, starting from restricting his fluid intake to more intervention by the oral medication and GDMT. And from the data what we have, this filling pressure increasing usually few days, up to 15 days, up to 30 days actually sometimes, before the patient's symptoms. And from our experience, many patients will start to adjust their diuresis before symptomatic, and they are calling us, why I don't have symptoms actually. And if they are waiting and sometimes not compliant to our order, they will be symptomatic after a few days usually. So we are really at the stage that we are preventing the symptom. We are not waiting to the patient to be symptomatic. And this is not a new device, actually starting the trial from 2011, and we reached up to 2025 and 26, and we have many trials. And this is one of the examples of the trial, started from the champion trial. In this champion trial is clearly showing 36 reduction heart failure hospitalization and improve the patient quality of life. Then to the MIMS HF trial, then to the guide HF trial, which is neutral trial. It didn't show significant benefit, but for me, this is very informative trial that include many patients, even with mild symptom patient. And the main reason mentioned that why this trial is more neutral trial that is done during the COVID-19 era, and was many restriction to adjust patient and seeing the patient and follow the patient. So they think this is the main cause, but we have many information from this trial, which we learn after it, and many trial like monitor HF trial and meta-analysis after that, that show the same benefit of significant reduction in patient hospitalization and improve patient quality of life. And what beyond symptom? It's clearly from the trial and evidence that this device can prevent the symptoms and prevent hospitalization and keep the patient in the good quality of life. But what we mean in this trial, on this presentation about the beyond the symptom? Let me give you one example of our patient. This is 65 years old man. He's ischemic cardiomyopathy with CABG in 2016. He's mildly to significant symptom. He had 2 to 3, and he have clearly recurrent hospitalization due to decompensated heart failure. He cannot tolerate the GDMT, and due to the CKD and soft blood pressure, ejection fraction 25% high. There is many markers that's showing this patient is mostly advanced heart failure, like NT-proBNP, CKD, which mostly cardiorenal from low perfusion, recurrent hospitalization. Initially, the patient, he said, okay, after diuresis, I'm doing good. I'm mildly symptomatic to asymptomatic. I don't think I'm advanced heart failure. So we think implanting cardiomems or BA pressure can give us more information and early detection of any advanced symptom of this patient. So we implant for him this cardiomems in June 2025. And when we monitor him, and you can see their pressure of high BA pressure, mean BA pressure almost 42, and the BA diastole, which reflecting the LVEDB is 30 on the baseline. So after that, we start to optimize him from his volume with diuresis and increase his GDMT gradually until we reach good GDMT medication. And what we notice, there is significant improvement in his BA pressure to be significant reduction from, as example, diastolic BA pressure from 34 to 27, and the mean from 44 to 31. And patient, he's on maximum tolerating GDMT at that time. But unfortunately, after 6 months, again, the BA pressure start to be increased. And patient actually at that time, he's really denied any symptoms. But what we notice, the BA pressure is going up, and the mean BA pressure increasing from what we mentioned 30 to 50 now. Renal function is worsening, creatinine is increasing, he's on good GDMT. So patient renal function worsening, he's asymptomatic. We think, or the team initially think maybe offer diuresis to this patient, we give him a lot of GDMT, but BA pressure is high. This is really conflict or confuse the team. So stopping the diuresis, actually, it's worsening the patient more from renal function and BA pressure. So we bring the patient, reassess him again with right heart cath, which showed really low cardiac output and high RA pressure and high weight. So we manage the patient with D-vitamin, Lasix, furosemide, and he's really advanced heart failure with cold and low perfusion and congestion, improving his renal function actually. So we assess him again. We think he's really advanced, but the patient really decline advanced therapy like LVAD. So the patient his mild symptom, he really was advanced heart failure. So we discharge him after 2 weeks, readmitted. Unfortunately, was in cardiogenic shock and long stay in the hospital, end with the arrest, and he passed away. This is another patient with 38 years old female, dilated cardiomyopathy, ejection fraction was 15, and she is NIHA 3. Actually, she looks at really advanced heart failure, severe ejection fraction, and she had recurrent admission not only from left, even right side with ascites and liver cirrhosis, and recurrent almost admitted 4 times in the last 8 months. You can see the echo, severe MR, and many RV is not that good, also severely reduced, and LV severely reduced. And you can see here, initially the patient was difficult to take care for any advanced therapy, and mainly due to many organ comorbidities. But the patient is young, so our plan to implant these cardiomems and monitor them. And you can see the pressure was high in the initial time with mean BAs around 42. The team is doing great to keep the patient euphylemic at that time, and after a few months, they can reach to the maximum GDMT, and you can see the significant reduction in the pressure of the patient to almost normalize as any normal patient. And BA pressure, the mean was dropped to the 21, and the patient was NIHA 1, asymptomatic for. And since that time, 2024, until now, the patient shouldn't have any single admission for heart failure or I mean, in general, decompensated heart failure. And even the team, they think maybe this patient is improved to the ejection fraction to be normalized. But we repeat the echo still, ejection fraction severely reduced. But we can see here in this case, another scenario when the PA pressure drop despite the symptom is really reflecting good outcome. So the first patient was asymptomatic, the second patient asymptomatic, but the first patient PA pressure was not dropped. The second patient PA pressure is dropped. So the outcome here was still for 2 years, no hospitalization with no symptom, but the first patient end with the death. So actually, we have many trials which support our thought that despite the symptom, PA pressure is high, it's really reflecting high or advanced heart failure. And starting from this remote PA pressure monitoring for 2 years to assess the mortality, which taking the data from all the big trial like Champion and Guide and MIMS HF trial, including more than 4,000 patients with heart failure with reduced and preserved ejection fraction, showed significant reduction of PA pressure. Is actually significantly decrease the mortality. Every 2 millimeter of PA pressure drop, almost more than 14% reduction in mortality. And if PA pressure is increasing by 2 or more, I mean, the PA diastole is actually increasing the mortality by 26%. And this is also reflecting the benefit in heart failure with preserved and reduced ejection fraction. Another trial, which retrospective also including more number of patients, more than 99,000 patients, that monitoring the same group, but they make the target is PA diastolic pressure less than 20 or more than 20, and actually they show the same benefit. That patient with persist PA diastole more than 20, for example, is worse mortality and less survival benefit. From that all point, we have now ongoing prospective big trial, including more than 170 center in the international centers, that they are testing the team this theories of PA pressure more than 30 or more can lead to the mortality. And actually, this is assessing in the advanced heart failure management. This trial called TMHF expected to be published maybe after 4 years. So KFMC experience, we have big experience with good volume of patients with cardiomyopathy. Actually, our experience starting or evaluation or our protocol in 5-step, starting from the patient selection. We are trying to select the patient who is really can gain benefit from this device, who is the patient symptomatic, recurrently hospitalized, no significant comorbidity like very low GFR or other comorbidities, and we rule out mainly technical or any problem that can lead to the complication of the device, like a pulmonary embolism, DVT, or another tear in the right side, or CRT, who is recently implanted. So then after patient selection, we try to keep the patient avolemic before implanting the device. Some of the patient need to be admitted for the IV diuresis. Some of them can be diuresed by the oral before implantation. And the main reason of that, implanting on the euvolemic can give you the hint what's the PA pressure baseline for the patient, and you can't easily put the target for the PA pressure to monitor them. Then after that, we go to the next stage, that we optimize the patient from his volume by optimizing his diuresis and GDMT optimization. And we start the GTMT for the patient from the first day of the implanting of the device, actually. Then our experience usually in this group of patients, usually you will have soft pressure and renal impairment. So keeping the patient euvolemic for 1 or 3 months, usually by our experience, can lead to the recovery of the PA pressure and can be optimized later on and tolerating the maximum or GDMT, which cannot be tolerated before. After optimization, actually, we reassess the patient after 3 to 6 months again, and we see PA pressure. If PA pressure is dropped, mean PA pressure drop less than 30, actually the patient is good prognosis, and especially if he's asymptomatic, we'll keep the same and just monitor him. And if PA pressure is more than the mean PA pressure more than 30, this is the patient with high risk and high alerting us again. So we bring the patient in the clinic, and sometimes we admit them for the re-evaluation. That mean they may need more device like CRT, more additional medication like hydrazine, isorbide, ivabradine, more structural like TEER for mitral valve, or sometimes they are clearly advanced and we'll go for advanced therapy. After that, we keep looping and re-evaluating the patient Every time improving not mean that patient will not be worse in the future. So we keep eye and optimize them as much as we can. Finally, take home message for in heart failure in general. My take message is initially mild symptom. That's not meaning this patient is not in bad prognosis. We saw many patients in the clinic that tell us they are asymptomatic and doing great. When we take more information, you will see this patient actually asymptomatic due to they are limiting their activity. They are not doing what usually their quality of life should be. So limiting the patient activity, it will make him less symptomatic. But actually, the truth, this patient is really symptomatic when he's doing the usual or expected activity for him. Usually apply, please, the advanced heart failure symptom. Don't depend only on the symptom. We have many evidence about that mild symptom with plus other independent risk factor like recurrent hospitalization, required some inotropes or high BMD, required high oral diuresis, and many things that summarize in I need help, which I don't mention here in this presentation. This with the mild symptom. This patient should be evaluated or referred to the heart failure consultant. BA pressure usually monitoring can lead to the prevent the symptom and can exceeding the symptom by the few days to 14 days usually. And BA pressure usually it's mostly is independent risk factor as a mortality in heart failure patient. Persist elevation BA pressure is with the optimal GDMT need to be re-evaluated regardless of the patient symptom. Thank you.
Thank you, Dr. Fahmi, for the informative presentation. I totally agree with you that heart failure is highly prevalent condition, especially in our region. I think we are doing great job and like optimizing medical therapy, but still we're seeing in our practice that recurrent admission, it's high, although like all this what we are doing with the GDMT. So maybe now we can hear the second. We can talk about. I can introduce the second speaker, and we can discuss the second talk, and then we can later we can discuss what's the heart failure and how can we help patient with the heart failure and avoid the readmission. So let me introduce the second speaker. Shams Al-Anazi is a senior advanced nurse in the heart failure and cardiac service at King Fahd Medical City, Riyadh, with over 15 years of experience. She leads heart failure initiative, including CardioMEMS, remote monitoring, nurse practitioner lead clinics, and patient-centered care program. She is actively involved in education, research, and advancing multidisciplinary heart failure symptoms service. Welcome, Shamsa. You can start, please.
Thank you, Dr. Nadia. Did you hear me?
Yes, we can hear you. You can go ahead.
Thank you, Dr. Nadia, for introduction, and thank you, Dr. Fahmi, as well. And thank you all for joining virtually this evening. Let me tell you about myself a little bit. I'm Shamsa Al-Anazi, nurse practitioner, as Dr. Nadia said, and I'm working King Fahd Medical City, leading telehealth monitoring. So, as you can see from the titles today presentation, the new era of remote heart failure management. So you might be wondering, what do we mean by new era? What has changed in the way we care for patients with a heart failure? So in this session, I'll try to explore how advances in remote telemonitoring are reshaping heart failure care. I will share our real-world experience at my hospital, KFMC, and telehealth monitoring is transforming the way we care for heart failure patients. Let's get started. So today journey, here is our journey today, patient screening and selection. We'll discuss the three phases post-implant workflow, the GDMT optimization, the patient education and compliance, our monitoring workflow in my hospital, when to escalate as a nurse practitioner, when to escalate to heart failure cardiologist, troubleshooting, and finally, I will discuss a real cases from our practice. So let's start with the technology itself. What is CardioMEMS? For this less familiar with the CardioMEMS, here is a quick view, as you can see in the screen. Is a small sensor, wireless sensor, require no battery, no wireless. Is implanted in the pulmonary artery during the right heart catheterization. So in the implementation phase and pressure and the daily transmission, each day the patient will lie in the special payload that wirelessly record and transmit BA systolic, BA diastolic, BA mean, all the data that we need, and heart rate as well, to a special system called Merlin.net. So if you ask me what is this system, is a secure remote monitoring platform that received and transmit the data from CardioMEMS device itself, which allow us as a heart failure team to monitor the patient remotely and to check patient readings every day. So also the intervention every day, every morning, as a nurse practitioner, I review these readings. If BA diastolic pressure start to increase, I can take action early by adjusting diuretics and before symptoms develop. So also I can say that here the research show that pulmonary artery pressure often increase around 2 weeks before heart failure symptoms appear into the patient. That early warning window can help us to prevent hospitalization. So who is the right patient and who is actually the right patient for this device? Screening and selection. So the slide here, it's outlined the workflow at my hospital for identify right patient for CardioMEMS implantation. So you can see here the process begin in the heart failure clinic and the heart function clinic, where the patient are reviewed by nurse practitioner. During this stage, we are focusing in early optimization of GDMT. Within first 6 weeks, we try to do our best to optimize. Then we reassess the volume status, adjust diuretics as needed, also identify a patient who may require referral to advanced heart failure clinic or referral to structure heart clinic or devices therapy such as ICD or CRTD. So once patient is identified potential candidate, we perform structure screening process using inclusion and exclusion criteria. I'm not going to go through it because Dr. Fahmi already mentioned. So once the screening process is complete, eligibility patients are reviewed in our heart failure meeting, where a decision is made regarding to the CardioMEMS implementation. So you might also ask, what are the benefits of this structure pathway in general? I think this structure pathway, it's help us to ensure that we are selecting the right patient who are mostly likely to benefit from this device, pulmonary artery pressure monitoring. So it's very important. So once the device is already implanted, there is 3 phases. Phase 1, post-implant patient evaluation. Phase 2, BA pressure optimization. In this phase, we are setting the individual target for each patient. Phase 3, BA pressure maintenance. Let's go through. So post-implant patient evaluation, this is phase 1. Once on the first day after implementation, we perform a comprehensive clinical assessment. We evaluate the patient overall recovery, and we check the respiratory symptoms, such as cough, hemostasis, which may indicate a pulmonary hemorrhage. Also, we assess the heart failure symptoms, including shortness of breath, orthopnea, or VND. Also, the procedure site is inspected for any bleeding or hematoma. Laboratory, of course, is important. CBC and renal function tests are reviewed as well. Also, we do chest X-ray to rule out any complications such as pulmonary edema, hemorrhage, or confirm, and also to confirm the proper device position. So also we encourage early mobilization as tolerated and provide education both to patient and family regarding to post-procedure care and post-CardioMEMS protocol. So we are still in the phase 1. We teach the patient how to take the readings. As you can see here in the slide, this image is demonstrate how a patient take their daily CardioMEMS reading using the patient electronic system. This is what we teach every patient before discharge. After CardioMEMS implementation, patients are trained to take their daily pressure using patient electronic system. Also, in the other side, you can see the antenna. The antenna is another device or machine we can use to check the CardioMEMS reading when the patient is admitted in the hospital. So in the phase 2, this is so how do we compare now the device already implemented. Now how do we compare this reading into individual targets? So in the phase 2, this slide shows us what we set individual BAD pressure target using patient first week reading. We set the target after 1 week from device implementation. So to set the target range, we first identify the patient highest BAD. So you can see here, this is an example of one of our patient. Week 1 reading, 25, 26. So the highest number is 26. So the highest reading 26, we then subtract 10. The result will be 16. The midpoint between these two values become a target, which is 26 plus 16 divided 2. It will give us 21. This is the method we're use. Finally, we create a range, which is plus minus 4 millimeter mercury around the target. So our target, we said, is 21. So our range, it will be 17 to 25. So what's this mean? As long the patient pressure remain within this target, 17 to 25, they are considered stable. In the phase 3, what we do when the pressure reading is high? First step, it's confirm location. This phases we are focusing in maintaining the patient target PA pressure. When a high pressure reading is detected, we first confirm a patient location, because moving to other city, to higher above sea level can increase PA pressure reading. For example, patient travel from Riyadh city to Abha city may show an increase in PA pressure that's related to the changes in elevation rather than worsening heart failure. I'm always asking my patient, are you at home? Have you been travel? Before interrupting on any elevated reading. We also verify medication adherence and repeat the reading the next day. If pressure remain elevated, we assess the symptoms. We reinforce fluid and salt restriction. We review medication compliance and check renal function. So based on this assessment, diuretics may be increased temporarily until PA pressure return to the target range. So what if the pressure is low? When we see low pressure reading, again, we confirm the location. As I said before, the location, it will affect the readings. Then we assess the patient for dehydration or for diuresis, review symptoms, and check renal function. If clinically appropriate, diuretics maybe we reduce because maybe patient is over diuresis. But an important point to remember is to look to whole clinical picture of the patient, not because not just the number. Also, low BA pressure with lower limb edema or ascites should raise a concern for RV failure in this case. So the low pressure can be misleading, and the priority is to immediately investigate and rule out RV failure rather than simply decrease the diuresis. So now, how to optimize GDMT using CardioMEMS data. The golden rule is the GDMT can only be safely up titrate when the patient is evolemic. So how we know the patient is evolemic? Of course, we are using CardioMEMS data, which is BA diastolic, BA mean. So we start with the ARNI, for example, interest. We initiate when the blood pressure more than 100 or more than 100. Patient is stable. We start with the 50, then 100, then 200 milligram. Monitor the blood pressure, renal function, and potassium. Then we go to beta blocker and make sure only beta blocker can initiate when the patient is euthyromic and BA diastolic at the target, and do not up titrate during the active congestion. MRA like aldactone, we ensure that potassium less than 5 and GFR more than 30 before initiating. Monitoring electrolytes is very important. Also, SGL2 like DABA and IMBA, it's benefit for both HFrEF and HFpEF. Patient education. None of this works without patient education. Patient education it's very important to educate a patient about heart failure, the risk of deterioration, and the importance of remote monitoring. Patients are trained how to use home monitor system. We perform daily readings correctly. We recognize warning signs and worsening heart failure, adhere to their medication, and know when to seek the medical attention or to call us. Actually, the goal is to empower a patient and help keep them stable and out of the hospital. So, but what if the patient, when the patient stop compliance? As we all know, not every patient will remain fully compliant. Some patients may feel that taking daily reading or become an extra task add to their daily routine, especially when they are feeling well. Other may simply just forget or lose motivation over time. When this happens, it's important that we reach out to the patient and understand the barriers and reinforce the value of regular monitoring. A few minutes spent taking daily reading can help us also to detect worsening heart failure early and potential prevent a hospital admission. We have a structure 3 steps escalate pathway. So we are using during the heart failure using the heart failure phone service. We send a WhatsApp reminder to encourage the patient to resume their daily monitor. If there no response, what we will do, we have phone call with the patient to understand any barriers or concern, answer their concern, and reinforce the importance of compliance. So what if the patient is still he is not compliant? So we arrange clinic visits involving the patient and family, not only the patient, to provide further education and discuss the potential risk of non-participate in the monitoring their reading. So what we explain to the patient when we bring them to the clinic, we explain the risk of non-compliance, like increased mortality risk, missing medication and daily reading is directly linked to higher rates of preventable death, higher morbidity, worsening symptoms, more frequent hospitalization, and reduced quality of life. Disease progression, heart failure advance faster without regular monitoring and medication. Impact on family caregiver, of course, non-compliance is increase the caregiver burden. Remote monitoring workflow at KFMC. So what does the typical day look like in our unit? The day daily, I came in the morning and check review BA pressure every morning. I look to the Maryland system and review all the active cardiomems patients. Check any alert management and manage the alert. Patient contact, call the patient, assess for symptoms, fluid balance, medication adherence, clinical decision. We take our decision independently as a nurse practitioner. We adjust the diuretics, optimize the GDMT, or to escalate to the cardiologist or heart failure cardiologist if we need. Documentation, of course, everything documented in the electronic medical record, follow up critical alert, and manage in the same day. So we treat this, it's like a virtual word round. So when we should escalate to the heart failure cardiologist as a nurse practitioner, so if there is still increase in BA elevation, BAD more than 5 millimeter mercury, above the target, despite 48 to 70 hours of diuretics escalation. So we start with the patient, we start to optimize their medication, but the reading is still high. So this is the time to escalate to our heart failure cardiologist. Also, electrolyte abnormality, hypotension, renal dysfunction, creatinine increasing or rising more than 25% from their baseline, or GFR less than 30. Also, if low BA with possible RV failure, as I mentioned, we have to escalate to the doctor to rule out the RV failure. I will give you a clinical example. You can see here in the right screen, a patient with BAD target completely symptom-free, no dyspnea, no edema, no BA mean increase, no edema, no dyspnea, and but we found that BA mean it was increased more than 30. That is hemodynamic signal of advanced heart failure. So what we do is escalate to the cardiologist for advanced therapy evaluation. Again, remember, symptoms tell us what's happening today, but cardiomems data shows us what is coming tomorrow. So we are preventing things it's happening tomorrow. Cardiomems help us to treat the patient before symptoms appears. Troubleshooting. What we do if there is missing or no transmission, we call the patient to confirm a reading was taken, check home unit is plugged and powered, confirm a patient location, re-educate about the correct position, contact about if this not work. Also, if unusual reading, verify patient was lying flat, check their reading, we're taking every day, correlate this with the symptoms, weight and blood pressure trend, repeat the next day before any intervention. Always correlate the technical issue with the patient clinical picture before acting. The number on the screen is a data, but the clinical judgments is ours actually. Here, let me share a real case from our cardiomems program. This is a patient who is 72 years old gentleman with ischemic cardiomyopathy, HFrEF, with an ejection fraction 30, He had CRTD implanted 2 years ago and post-cardiomems 3 months ago. So current medication, this patient, he was in furosemide 60 milligram BID. He's in metalazone 2.5 PRN, bisoprolol 2.5, Entresto 200 milligram BID, aldactone 25. So during routine remoting monitor, when we are monitoring the patient, we notice gradually increase in his PA diastolic pressure over 3 days. And this is what suggests early fluid accumulation. So what makes this case particularly interesting is that the patient felt completely well. He reported no shortness of breath, no lower leg edema, heart failure symptoms is really free. So if we had relied on the patient's symptoms and what he said, we have considered him as stable and taking no action. But however, cardiomems data tell us a different story. It's detect that feeling pressure before any clinical symptoms appear, giving us opportunity to intervene early and potentially prevent the decompensation. So if you were manage this patient, what would your next step be? Would you first verify the reading, or would you act based on the hemodynamic data? So let's see how we manage this case. We call the patient and we confirm the location. He was in the same location. When then we reinforce the salt restriction, fluid restriction, and the salt restriction as well. And we increase the furosemide dose to 80 milligram BID. We also consider adding SGL2 inhibitor as a part of GDMT. The result was very encouraging. Within a few days, the BA diastolic pressure returned to the target range and hospitalization was avoided. So the patient feel well. He had no symptoms, no warning signs, and no reason to seek any medical attention or to call us. But when we do our daily monitor, we recognize that cardiomems data showing a congestion sign early before the symptoms is developed. So what we have learned from this case and from many patients, we are following through remote monitoring that the cardiomems, it's true that is the true value of cardiomems. It's allowed us to move from reactive care to proactive care, treating hemodynamic change before they become clinical events. So this is what beyond symptom really means. So take-home message. Let's wrap with the take-home message. Proactive cardiomems enable proactive heart failure management. Proactive care cardiomems would detect deterioration 2 weeks before symptoms appear. Target selection, use the simple method that I mentioned to set individual BA goals. Reassess every 2 weeks until the target is stable. Adjust diuretics, rising BAD, act now. Gradually loop diuretics, increase gradually by BA data. Always check renal function test. Optimize GDMT. Confirm evolumic by using cardiomems data. Also, you have to know when to escalate high BA, hypertension, acute kidney injury, electrolyte issue, RV failure concern, or call the heart failure cardiologist. Here is a quick look to our heart failure nurse practitioner service in my hospital. Our heart failure nurse practitioner service, we are covering outpatient care, IV diuretics, clinic, inpatient heart failure management and consultation, telehealth service, and nursing education. And thank you so much for being with us this evening. I hope this session has given you practical tools to take it back to your own telehealth program.
Thank you,
Thank
Shamsa,
you.
for an amazing presentation and discussion. So we're going to start now with the discussion. And please, if you have any question, you can type it in the Q&A section. But let me start the conversation and discussion with the amazing speakers, Shamsa and Dr. Fahmi. So nowadays we have this technique and the remote monitoring by using cardiomems, and we can monitor patient from home, and then we can adjust his doses or diuretic doses based on our numbers. And I don't know, you have an experience, Dr. Fahmi. Did you notice a difference on the readmission by using cardiomems in your practice?
Yes, actually, we are collecting data of our patient, starting to record their data from hospitalization pre and after cardiomems. And also, not only this one, we record even their quality of life using the Kinsa score Kinsa score questionnaire for heart failure, and monitoring their symptoms also. In hospitalization, actually, we record as international significant reduction. Our average for patient hospitalized before, actually, our program is starting as really some highly selecting program for the patient who is really hospitalized, and we try to get more benefit for the patient is really symptomatic. So we record patients with really hospitalization of average from 4 to 6 times per year usually. And our reduction as per data is dropped to one or less than one per year. Most of the patients, we don't have record. We have some record initially for the patient, but mainly for non-heart failure or non-cardiac reason. But for heart failure in general, we have. And the main reason why we have some of the non-cardiac, the age of the patient, most of the patient, they have higher age and some comorbidities, so still they have hospitalization for other reason. But in general, yeah, significant reduction.
Because
And actually, Shamsa, she's the one who's recorded the data, and maybe she knows more than me about it.
Shamsa, do you want to comment or to give your insight?
Yes, I just want to say that based on my data or our data that we are recording, we really notified there is the admission or ER visits for a patient with a cardiomems require IV diuresis. It's really decreased, and it's a huge, it's a huge results. And this show us how it's important to put the patient with heart failure in cardiomems. It's to avoid hospitalization or ER visits.
Yeah, I agree with you, because with the traditional remote monitoring, usually we have like challenges, and like in a patient, we have to ask him to wait himself and to be, and when we interfere, patient already will be symptomatic. But with cardiomems, we can detect it before the symptoms also, and so we can adjust the medication. So there's a question that from in the Q&A section, that what is the incidence of pulmonary embolism with the cardiomems? Dr. Fahmi, do you want to take that
I
question?
can take it as the one who is implanting this device.
Exactly.
Actually, for safety, we don't have any issue for safety of the patient. Most of the patient is implanting successfully without any complication. Maybe you will have some irritation sometimes in the first hour after implanting the device, but it's very rare. I can tell you, maybe I saw only one or two patients maximum that they will have keep coughing and some mild hemoptysis. Otherwise, we didn't have any problem with the safety for implanting the device. Pulmonary embolism, we didn't see any pulmonary embolism. No, this device, a small device, depend on the procedure to select the proper artery, proper size, which was around 10 millimeter. So after you implant, we didn't see any problem about the pulmonary embolism. Actually, pulmonary embolism is preventive. If we have recent pulmonary embolism within, especially first month, usually we don't implant, or first 6 months of some of the patient.
Yeah. So then there's another question: can we use it for dialysis patient?
The problem, this device you will implant to adjust the patient diuresis medication. So you should select the patient who will respond to your treatment. Implanting for dialysis patient, that you will guide the other department, dialysis people, to optimize their diuresis. So from heart failure point, if we implant for this group of patients, we don't have any medication that can be managed through our department. So we don't implant, no. GFR, select 30 and more.
Yeah. So there's a nice question. Can we consider removal of the cardiomems? Can we remove cardiomems?
Cardiomems is a very small device that will be individualized within few months to be part from the patient. So no need to be removed usually, and usually it will be part from his body.
Okay. Yeah. So, but like, some people, they like, we list them for transplant, for example, and then they have recurrent admission, and they will wait longer. Maybe this patient can be benefit, but patient who's in dialysis, because we can optimize them by dialysis, I don't think there's indication. By the removal of the cardio, that's my opinion. Removal, I agree with Dr. Fahmi that it will be already part of the vessels, the vein, I mean, the pulmonary. So I don't think there's any that we can remove the cardio MEMS. Yeah, do you agree? I don't think it's possible to remove it. Yeah. There is a question, maybe.
Actually, it's the same idea of a stent. We don't remove the stent,
Exactly.
even if it's
Yeah.
not working well. Yeah.
Yeah. Transplant maybe with a solution only. Yeah. So there's a question for, I think, the Shamsa. There's what's it? Yeah, how cardiomems help the nurses to reduce the workload and optimize their management. Interesting. Yeah.
Sorry, doctor, can you repeat again?
How cardiomems help the nurses to reduce the workload and optimize their management.
Cardiomems, it's helping us a lot because we are monitoring a patient while he's at home, while he's with his family, you know, he feel comfort, he's not feeling stress. So we are managing him based on their compliance. If the patient compliance and her family caregiver are compliance, this is very easy for us actually, because all the data it's helping us to detect the situation for her. For example, before patient becomes sick or before the patient feels the symptoms, we already detect that the patient is going to be symptomatic. So we already start to optimize his medication. We start to increase or decrease diuresis and avoid the symptoms before it's happened.
Yeah, and also it will help the nurses by because also the IV lasers runs by the nurses.
Yes,
So you can optimize him remotely by
by home
tablet
care.
doses of diuretics.
Yes.
Exactly. Yeah, and
And we
instead of
have also home care IV diuresis. If we feel that the patient he need
yeah,
IV diuresis at home, we send the home care and we arrange with the home care and the patient to receive a course of IV diuresis and observe the patient daily while he's at home and he's receiving IV the lasix as well.
nice. Yeah.
Yeah.
So there's a nice question.
If
I
you
think.
allow me, Dr.
Yeah.
Nadia, to add only about the workload,
Hmm.
actually, smart system is not a system that I need to monitor all the patient one by one. Actually, it's sending for us the report for the patient who is not achieving the target. So, for
Hmm.
example, if you have one patient, 100 patient, you don't need to see 100 patient exactly daily. The monitor
Yeah.
itself, it will filter for you for some of the patients, like 10 or 15 patients per day, that you
Hmm.
mean maybe you need to adjust their or review them more.
To
So
call
yeah,
them.
it's really reducing the workload. Smart system.
Yes, yeah. So here another, can remote pulmonary pressure monitoring service indication when it's the best time to refer the patient for advanced therapy like LVAD or transplant?
This question for me, actually, yes, it
Yeah,
helps.
it helps.
In
Yeah.
both way, patient who is in the list transplant, he's still at risk. So we need to know how we
Exactly.
need to monitor him early to prevent hospitalization. And not only
Mm,
this one, we need to detect him early for maybe if he's for transplant list to be ready for LVAD, for example, if we think he's not improving or worsening rapidly. So yeah, can prevent in heart transplant. And the LVAD actually, we have good experience in this one, who patient and the cardiomems and shifted to the LVAD, that we can detect even the proper time to send him for the device. Actually, when you are monitoring the baby pressure and monitoring his daily volume states, so you can select the best day for to go for the device implantation, the LVAD implantation.
mm. So, what is the estimate cost for each device? That's interesting. If we'll compare, I think that I can interfere, and then Dr. Fahmi will take your opinion also on that, because I think in UAE we are using the insurance system. I don't know in Saudi Arabia how your practice. So, if we will look at the heart failure and the readmission, it's really a cost to the healthcare system, because each admission, the patient, especially if they're elderly, they have another complicate or another disease like diabetes, kidney failure, and whatever. So that's all costly. And if we will imagine that in 1 month patient needs 2 times at least admission or visit to the clinic or to the ED, that's all costly. But by reduction, the readmission or a patient's visit to the ED, that will help and improving or reducing the cost. So today and nowadays, especially nowadays with this new innovation and the AI, all the people's using now any tele home monitoring or tele devices for the remote monitoring. So maybe, Dr. Fahmi, what's your insight? Because always people ask me this question about the cost of the device. We have to look at the big picture, yeah, about the readmission and the disease burden. Yeah.
If you look for data about the cost effectiveness,
Mm,
and we'll take the most country who's really restrict or high alert any device for cost, like UK, for example.
mm,
That really we will not introduce like this device unless clearly there is cost effect. The data coming from UK, for example, the trial and evidence what they did for cost effectiveness, it showed that clearly cost effectiveness depend on the selecting of the patient. You should select the patient who is really needed, hospitalized, as you mentioned, recurrent hospitalization and symptomatic. If you select this group of patients, the cost of hospitalization, as we mentioned, is mainly the cost in heart failure. As keeping hospitalization for sure, the cost will be very high, and cardiomems, regardless, the cost will help the patient and help our system. And the cost is not coming also from only that we decrease the patient admission and cost in the we know, for example, in governmental healthcare we have a bed availability challenge for many patients. Serving this bed for another patient and prevent hospitalization for this heart failure patient is really more additional cost for reduction in this group of the patient. So yes, many trial we have from many countries, including US, from Europe, and we hope if we'll have in the Middle East, that's really cost effectiveness if you have select the proper patient.
yeah, for corporation. So there's some the more very active attendings. They say like they ask now compared cardiomems to invasive monitoring, PA catheter or SWAN in the ICU patient. Is it accurate? Okay. Like if you compare the cardiomems data and the PA catheter or SWAN, is accurate?
Technically, yes. Actually, we are
Yes.
calibrating between
Mm,
when we implant the device, we
mm,
calibrate this device to the pulmonary artery lively in the same time. So it's the same numbers.
yes. So, can remote monitoring identifying high-risk patient earlier than biomarkers such as NT-proBNP? I think that we answered before. Yes, it detect earlier before the symptoms and high NT-proBNP. Okay, so I think we covered all the questions. That's, mm, 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 mm. Can you consider removal? Okay, so maybe if like I ask you, Dr. Fahmi, if you wanna like give a one message or like one take home message to the attendees, what you will give them.
Usually, I might talk home message for the patient in heart failure. And as you know, Dr. Nadia, you are heart failure, and you know, assessing the patient, regardless of the pressure, assessing the patient simply that any patient he come to your clinic and he told you and you ask him how's your symptom and he tell you I'm okay. That not mean the patient is asymptomatic. Many patients we saw the notes and patient is asymptomatic until we reach the patient to the cardiogenic shock and they are. Actually, you should know our patient or internationally and especially in our region that the patient after they have initially heart failure symptom and short of breath, they will change all their life and they modified their life to be limited to the limit of this symptoms. That means if if his symptom will start with 50 meters, he will not exceed for all his life. He will limit that. Even to home, some of the patient, you see patient is younger, 40 or 30, they limit their activity to this symptom. So mention the patient asymptomatic is very critical for the patient. Many patients we saw is advanced heart failure. This is all not is asymptomatic. The other message that we are really the patient, if you have patient that
Want to say that.
recurrent hospitalization with these symptoms, especially the patient who is you think is maybe in between advanced heart failure or no, you have questioned that. I think this new era of monitor them is really promising that we can manage them well and early detection, detecting him with good outcome in advanced therapy.
Mm, mm. Especially our population. Also, when in the clinic, ask them, "Are you okay?" Yes. Symptoms? No, I don't have any symptoms. Then, when you will examine, like cold extremities, you send them to the ED, send the lactate, it's high. So, I agree with you. Symptoms, especially with our lifestyle, patient be every time say, or sometimes people like they'll adapt maybe to the symptoms or be scared to be
Yeah.
admitted and say, yeah, I'm fine, I don't have any symptoms. So I agree with you, this like really change our practice in the heart failure field by having such an amazing like cardiomems devices that remote, like monitor the patient remotely. So Shamsa, can you give us a one take-home message?
Yeah, so as I mentioned before, so I want to say that proactive care, empowered patient, and collaborative teams, this is the future of heart failure management. That's it.
Yeah, thank you so much.
Thank you.
So, and now I think we'll reach to the end of our webinar for today. And thank you everyone for joining our webinar today. And a special thank you for our speaker, Dr. Fahmi and Shamsa, for their informative presentation and great discussion. We hope you all found this session as useful, and it's gained your practical knowledge that you can apply it in your clinical practice. Please don't forget to fill the survey to be able to get your CME, and you will get CME, I think, as was told by Hisham, that after four days from today, 4 days. Good night, and inshallah, we'll see you in the next webinar. Thank you so much.
Thank you.
Thank you.